On page 43, we see the procedure for administering NG tube medications. You want to aspirate the stomach contents. Now, depending on your facility protocol, you will either test the pH to make sure you have the stomach contents. It used to be you returned it and you listened to the stomach growl. Now, per the book, that's considered to be no longer a reliable method, but you will still see it used. This is how we gave meds when I was at the hospital, and this is how you may see meds given in a facility through a tube. If it is facility protocol, check gastric pH content or gastric pH. If it's not the protocol, then you're going to return the stomach contents. You're going to listen for the gurgling sound, like the stomach growling. Now, you would have already listened to your patient's breath sounds, hopefully, as part of your bedside assessment. If you have a patient with an NG tube and you hear something different, meaning all of a sudden in one area of the lungs there's no sounds, we always have to suspect that the tube has traveled and liquid has entered the lung. That is extremely rare, but you always have to think of it. So hopefully, even before you give these meds, you already would have listened for breath sounds. If you have not, as part of your assessment, make sure you do it before you give the meds, just to make sure that there's no funny business going on with the tube and the lungs. Then you're going to put the medication into the tubing, and then you will instill it per gravity. That's best practice. Sometimes you will see a nurse take a big old syringe, suck up a whole bunch of liquid, and then shoot it into the patient's tube. Really not the best way to do it. It can bloat the stomach, it can cause gas and discomfort. And if the tube is a little bit clogged, you could split the tube. So the best practice is to take the plunger out of the syringe and pour the liquid medications in and let them go in by gravity. Then you are going to flush them with a certain amount of water. Once again, that depends on protocol. Usually at least 30 milliliters of water to make sure that it has gone in. Now, most places will have you check for content, give the meds, then flush with water after each administration. Some places might have you check for placement and then put water in before you do your meds. It just, once again, depends on the protocol. Make sure when you're getting any kind of an orientation to a facility, if you have tube meds to give, get a trustworthy nurse who knows the policy to show you how it's done, or read the policy. Better yet, read the policy. If the NG tube is attached to suction, if the NG tube is in just to keep the stomach from being bloated with gastric secretions, you don't want to turn right around and have suction pull the medication back out. So you want to clamp off the tube and wait 30 minutes before you reattach suction. It's generally accepted that liquefied medications will absorb within 30 minutes inside the stomach. Remember, some forms of meds cannot be crushed. Check with the pharmacist, and you might need the healthcare provider to give a new med order. All right, so that's enteral. Then we're going to move on to parenteral, which is on page 43. Enteral means enteric, which means into the GI tract. Parenteral means through the skin. And so generally when you're talking about parenteral administration of meds, you are talking about giving medications through various kinds of injections, whether it's intradermal, subcutaneous, intramuscular, or intravenous through an IV. On page 43, the rationale for giving parenteral drugs is on a list, why it's a good idea. And then there are reasons why it's not always a good idea. Unlike meds into the GI tract, which in a pinch, in an emergency, you could get the patient to get their stomach pumped or to induce vomiting. Generally, we wouldn't, but it's possible. Once you've injected something, It's permanent, especially in the IV. And so that's a disadvantage. The cost can be higher, but most of the time the advantages to giving parenteral drugs, whether injection or IV, outweigh the disadvantages. In box 4.1 on page 45, you see that it tells the steps of giving parenteral drugs. Make sure you read those. There's also a top tip for safety. When it comes to administering medications, read that. Now, note on pages 44 and 45, you talk about the different kinds of needles. You will be having an injection lab with me, if you haven't already, where we'll talk about the different kinds of needles, but we are giving out a handout that you can cut up into small pieces. I print off what's on page 45 and give it to you, and you can just tape it to your clinical notebook so that you can quickly remind yourself what an appropriate needle size would be for various injections. Now, when it comes to giving injections of various types, it's important to know what kind of equipment you're working with. You've got syringes, and they can be made of plastic mostly. There used to be glass syringes. You don't see that as much anymore because of breakage and can't be reused. There was a day, and I'm so glad we are past that, there was a day that nurses had to take glass syringes, wash them, boil them or otherwise sterilize them, as well as sharpening needles, cleaning and sterilizing those. Thankfully, we don't have to do that. Now, the downside of that is we have mountains of medical waste that every year are put out into the environment, so it's always a trade-off. But generally speaking, you're going to see plastic syringes. They're going to come in all sizes, from 1 milliliter, which is considered, they call that a TB syringe, many times used for intradermal injections, but sometimes for sub-Q. 3 milliliter, which is the common size used for IM injections, 5, 10, 20, 50. Generally for checking your tube feeding and administering meds, you're going to have a syringe that's like 50 or 60 milliliters. For diabetic meds, we've got unit syringes, usually 30, 50, and 100, although I have seen smaller. I had a cat once who was a diabetic, and I had to give him insulin injections, and they were 12 unit syringes. They were perfect. They were wonderful. But sometimes you have to draw up more than that. Make sure you look at pages 44 and 45 at the different types of syringes and how to select them for the various kinds of injections. And of course, we'll talk about that more in injection lab if we haven't already. Needles. Needles are measured in two ways. You're going to assess the needle length and the needle gauge. The gauge shows the diameter of the needle across, how big the needle is from side to side. The smaller the gauge, the larger the needle. So if somebody's coming at you with, say, a 15 gauge needle or a 16, they're going to be a little bit bigger, designed to allow more fluids in than, say, a 24 gauge syringe or a 26 gauge needle, that are made for people with teeny tiny veins and little babies. Depending on the company that makes the equipment, around here, the hospitals I've worked at, the gauges have always been in even numbers, 14, 16, 18, 20. You might see a different company that makes odd gauge needles, but it's an inverse relationship. The larger the gauge, the smaller the needle. Length is determined by the depth of injection. How deep do you need to go? You don't need a very long needle if you're doing a TB test where you're just going under the skin. But if you've got a injection into a gluteal muscle, you're going to need a longer needle. Many times needles have a detachable hub. In this case, the needle can be changed. And the rule of thumb is, if you can change the needle after you drop all the meds, do, just to make it more comfortable for your patient. Some needles can't be changed and you just have to go with it. There are sometimes specialized needles. Filters are sometimes put in certain kinds of needles for drawing up meds from ampules. Ampules are little glass tubes. And the school of thought is that little microscopic pieces of glass could drop down into that ampule. Some places will make you use a filtered needle when drawing meds from glass ampules, some places will not. There are different kinds of needleless systems. Sometimes there are like high pressure setups to drive a substance through the skin. It's not painless, give me a needle any day. But on page 44, you see an example of some needleless IV systems where it cuts down on the risk of getting stuck because you've got certain syringes that just fit into the rubber port. However, you have to make sure all the equipment comes from the same company because one company's needle won't fit into another company's port.